I'm now gonna turn it over to Bin. So Bin Yu has recently spearheaded a tremendous effort in her lab to collect data about COVID and to create a database of of reliable information about COVID-19. She also has recently published a paper about it in the Harvard Data Science Review that is linked in the content library that goes hand in hand with this event. So, Bin, I'm going to turn it over to you. Thank you for being here.
Thank you. Thank you for inviting me. And it's really a great pleasure to follow Nicholas' very inspiring talk. And next, please. Slide. Yeah. So this is really something my group jumped in March when we saw all this coverage of PPE in badly need. And we usually do machine learning, statistical genomics, neuroscience, but this is something we felt that we could help. And when there was a call from Responsible Life, a newly established nonprofit organization, we jumped in. Next, please. So most of my lab joined, and in the summer, we're actually joined by people from Google as well. Next, please. Next, please. So that's the goal. And the first task we were faced was actually curating a data repository, because this is the first project we got down that we didn't have data. And we basically used whatever available publicly and use some also connections with colleagues like Sam from Northeastern. US Facts has, and also New York Times had the county level case data. We decided to go for the case county level because most people working on the state level. Since we want to distribute the PPEs across the country, we felt like state was not fine enough granularity. So we went for the county level, and likely there were data available. We also curated a lot of data, social health, and other factors we think might be related to the death counts. We also made a choice to go for the death counts instead of case as a surrogate to predict the need for PPE for different hospitals, because cases, as we know, that depends on how many cases, how many tests were done. And that's there's inaccuracies, but still a lot more reliable. And even though we don't have it at the hospital level, facility level, we have data on hospital like employee numbers, so we can kind of impute the need. Next, please. So here's a bird view of the hospital level, county level data. There are about 7,000 hospitals in the US. Each of the hospitals will have about 200 features about their locations, how many employees, how many beds, how many ICU beds, and their ratings, and the ICU occupancies. And on the right column, we also collected the COVID data, the deaths and case numbers, and also demographics, population density, age structure, as we know that age is a factor in death rate, health risk factors like heart disease, lung disease, smoking, diabetes, and also socioeconomic risk factors. So all this data is at GitHub that you can use for your own study and your understanding. We also have a website I'll introduce. Also, we start going for some mobility data, but didn't find it, all the data we had was too useful for the prediction at the county level. And so we keep collecting data. We have some Kinsa data, temperatures, and some flight information between different cities. So it's a pretty extensive database we curated. And it's automatically updated for all these dynamic numbers like case numbers and death numbers. Next, please. So there are data quality issues. And as we know now, there were undercounts of deaths, like up to April 14th, a lot of counts now have proper deaths, like New York City has proper deaths. Next, please. And we decided to go for US Facts because they both, and New York Times, come from the same source, basic county level deaths and case counts, but they probably scrape the county level data at different time, do different cleaning, so they don't always agree. The reason we went for US Facts, because for US Facts, the different New York City is not just one number. they have different counties or different districts of New York City. So that's the reason, because at the time things were really happening in New York City. We didn't want to have just one big number for the so-called city. Next, please. And here just show you that, most of the time they agree, but there's some differences and they can be as large as a few hundreds. But with like 3,000 counties, it's not too big a concern. Sometimes the revisions does cause problem for our prediction, but that's just something we have to live with, unless you have really quality control at each county level. Next, please. And there's also weekday effects, right? Next, please. You can see that the number of death counts, there's definitely a daily pattern, depends on which day of the week. We think this is probably reporting delay. People probably don't work over the weekend, and therefore the death count over the weekend got reported on Tuesday, more like Monday might be too early. Next, please. So there are also historical data revisions. Next, please. And there was one case that you can see this small number near 1,000. That was a case, I think was a human error. It's King County in Washington, where I think it should be like 500. Some deaths was entered as 1,500. So later got corrected. And because the correction, you have this stripe of data revision continuously revised. Next, please. So it's imperfect data, but that's the best we can. So we want to predict 5 or 7 days first, and now can also do 14 days short-term prediction. This really dictated by the group we support, because it's enough to do 5 days for the shipment of PPEs across the country. The source of the PPE come from the local makers who use materials to make these masks. And then we work with other organizations to ship the PPEs around the country. First, we develop many different predictors. And then we also have a pretty non-parametric way, just use the past prediction errors to come up with a prediction interval. And we still maintaining a website to really visualize our data and to have our information updated, more like automatic AI system to have, I'll introduce the website later. Next, please. So that's what we set up to do. So next, after we collect data, we continue to collect the data, create the data. We have actually a data team. So with 12 people before the summer, we had different sub-teams, data team, modeling team, like a reading news team, and other people just help along the way. So it's quite an interesting team dynamic, but people work really well. Basically, many of my students drop anything, like everything else, and we work on this from March to May, nonstop for 2 months, and continued over the summer. Next, please. So there were a lot of courses in the semester, very dynamic data. And long-term prediction have to do with feedback. I think we still, the modeling community struggling with accurate or anything. There are different teams giving very different long-term predictions. And we aimed at short-term. And we want to do it for all counties in the US instead of a particular state. Next, please. But the blessings are actually, we have always feedback, like how well we do. So it's a great reality check. We have to keep us honest. And next is that for PPE supplies, we could, 7 days is good enough. And we actually can do 14 days reasonably well. Next, please. So we had different teams of people work on the develop many different predictors. And the idea is that we kind of have parallel people working. We have separate county at the time. When we started in March was exponential growth, we have exponential predictor. And then we have linear predictor, just past 5 days, fit a linear trend for each county. And then we also have shared like parameters across different counties in exponential model. And then the fourth one is we try to use some demographics and to see whether they'll improve. And then we also have the fifth one, which is just use the case and death numbers from neighboring counties and the county before, and also use the weekly effect 7 days ago, and then do the prediction. Next, please. And we have a way to combine. So this combination idea really came from 20 years ago. I was at Bell Labs. We're combining different predictions for audio compression. So this is really something you can put it under the minimum description length principle. Idea is very straightforward and simple. You just look at the last few days. You have discount factor mu in the past like a month ago, how well you did doesn't matter too much. You just look at the past few days and you give more weight to predictors where it worked well for the last few days. And then you weigh them exponentially with the error. And then you have C control how much you want to put with the best predictor versus the others. So that's worked really well for audio signal. We fixed the mu and C from that paper because I was really worried about overfitting. And the reason why it works here is that audio signal with both lyrics and also music was very dynamic and changing all the time. This is before podcast time. At the time, we won't support the podcast over internet. And this is just signal, very signal processing or machine learning approach. Next, please. In the end, we end up using the square root because some accounts kind of have a long tail. We try to make things a little bit more comparable. We took a square root of the counts and use this as the error, which is all the numbers, 0.5, C was 2, and mu, I think we use 0.5. And then we can combine all the 5 predictions in a way. But it turns out 2 of them work much better. So we end up just using 2 instead of all the 5. So there was this kind of screening using the data we had. Next, please. We end up using number 2 and number 5. Number 2 is just very simple, linear, use 5 days, do a linear prediction. Number 5 takes a little explanation, but intuitively, it's kind of using the loss function from a Poisson regression as a machine learning surrogate loss function. And we use yesterday's death count, and 7 days ago, the case count from the same county, and the neighbor death count 7 days ago, and neighbor county add up case numbers 7 days ago, and that's it. And we share all the parameters across different counties. And we use the weighting scheme we call CLAP now from the earlier audio compression paper, and that's what we end up using prediction up to today. Next, please. So when things are linear, we kind of put more weight on the linear predictor. When things are more exponential, we put more weight automatically. This is not humanly tuned. So here you see 3 plots. Just let's concentrate on the first plot. This is just a raw scale absolute difference between your prediction and the past, and over across different days and across different counties. This panel of plots try to show you that the combination really worked. So the red corresponds to the linear predictor, and the kind of yellowish is the exponential shared, and the blue is the combined. So most of the time works better. And the last one is the most interesting because this is using the scale square root as a measure of prediction error. That's what we use in the weight. So you can see the advantage of the blue curve is much more obvious. But it's interesting to see that for the 2 other errors, one is just absolute difference, the other is relative error, with the blue curve still turned out to be the lowest. In the beginning, you can see there's a lot of variability, and just we couldn't have much data to really do well, but eventually it's also because the total number gets big, we get a pretty good handle on the total accumulated prediction error. Next, please. This is using the same color, but the same matrix for 3 curves, but the curves mean different things. We're looking at different horizons. 7 days is the lowest, yellow 10 days, and blue 14 days. It shows that for all different 3 metrics of prediction error performance measure, it's very obvious that it's harder to do 14 days than 10 days than 7 days. And next, please. This is just to show you that if you push to 21 days, there's kind of a linear rise, right? It basically you pay a price when you go more into the future. The way we do it is actually we do the second-day prediction, and then we use the past pretending the second-day prediction become the real prediction, and we just keep bootstrapping up for future days. So the method works, you can keep going, but just the reliability, because the dynamic of changing dynamic of feedback loop, the method is not able to predict into the future because we don't take into account the feedback loop. But on the short-term scale, there's implicit taking into account the feedback loop because we just see the trend of where the death count is going. So it's not a big problem without explicitly modeling the feedback loop. So I think this is more signal processing, machine learning, or statistical approach. It's a good complement to the more agent-based approaches, modeling explicitly the interactions, the networks. And for example, we could possibly combine for short run and constrain the other models, which is more involved with this more straightforward trend following approach. Next, please. So I have talked about the predictors. We end up using 5 when we develop. We end up using 2 instead of the 5 we developed. So the next thing we wanted to do is give you a prediction interval. It's not enough to say, well, it's about 500. If you want the hospital to be like prepared, you want to give some interval so they know that really they should prepare for 500 beds or they should prepare for just exactly 300 or 350. So we're going after interval prediction. Next, please. So the idea we use is very simple, can be put really under the conformal prediction. This is all data you can see. Santa Clara, that's where California had a lot of cases and death relative to the other counties. We just look at the last 5 days and look at the relative prediction error for our method. And then we take the maximum. Next, please. And then we just add up to the prediction, top and bottom. Since we're looking at the cumulative deaths, if we go beyond the last death we observed, we should definitely truncate there instead of just going below. And that's the interval we get for the prediction error. And we can do some calculation. If the prediction error in terms of relative scale are exchangeable, you can show that this way we'll get about 83% coverage. So that's kind of a rough calculation. And next, please. This is to show that if everything is exchangeable, you show the ranks of the different residuals will be more uniform and between 1 to 6, so the average 3.5. This gives you some indication. On average, we kind of okay, but there's variability. But the proof of this method is not really the theoretical calculation. It's really, we can just see how this interval really cover the observed death counts, because we have many, many days to come and many, and that's what the empirical measure in the conformal prediction analysis. Next, please. So here, see, if you look at the period, the first period, April to May, then the coverage, we aim at 83% under some, observed seem to be okay assumptions. And most of the intervals coverage is actually above 80%. There are a few below. And if you look at it, it's because a lot of times there's a sudden jump. Either just something happened, there's a super spreader event or something, or it's because a revision of death count. So and then the method have a hard time catching up. And if you look at the May 11 to 12, the coverage is still pretty good, but the intervals are relatively long. But if you only look at the days where you have enough deaths, that's what we're really aiming at when the PPE will be in shortage, then the interval size is a lot more decent. Next, please. Next slide, please. So now we have seen that we have now an interval which has pretty decent coverage. Then we move on. Chandon, actually is my deputy, a CS student in my group, start building a website. And we start displaying a lot of our results at our website. So that's still up, called covidseverity.com. Next, please. So this is behind the covidseverity.com. It's really an automated AI system. We did curation of the static features about health and density, economic, socioeconomic situation, all of that. And that's already put in there. We're still adding some things when there's opportunity. But the daily counts are scraped automatically from US effects. And we do some automatic cleaning, as I'll show you, that doesn't always get to the problem. Like this 1,000 like change, which if you human look at it, you know that it's an error, but the machine didn't know. And then our CLAP prediction algorithm runs on automatically using AWS. So thanks to AWS for supporting us. And also we have our MAPI intervals also calculate. MAPI means you use the maximum of the past prediction errors. And the AI system could not spot the problem, as I mentioned, that the King County, Washington was just later got corrected. So humans in the loop would be better. So I have been kind of the only human in the loop. Each time I give a talk, I look at the website and spot something and then let the people fix it. So I hope more people look at it. And there was one person actually just somebody out of the blue really helpful, find some also debugged for us too. So we really need a human in the loop, but right now it's mostly the machine doing the job. I'm the only human go there while I give a talk. Next slide, please. So I see the future of AI as human-machine collaboration. So this is just a snapshot of our website. That's the front page. We have on the left is the total cumulative number of cases, because I have to submit the slide earlier this week. So that's where I did the 12 last week. And you can press the blue button, which I'll show you. On the right-hand side, I'm trying to go a little causal, but not quite there. So did a little work, hope other people find useful. Give you a way to cluster different counties and do some offset when there's 1 or 2 cases. Or you just say, that here's the county, find the 5 counties most close in terms of the trend. So some minimum ability to cluster. It's beginning of I'll say causal investigation, which is very difficult. But if you use the operational definition for causal inference, which is you want enough evidence to act, then we're definitely in causal inference, not in terms of mechanism drive, but I like that definition. I think it's from Nancy Cartwright from Stanford, and this is where I read her paper. It's just like you want enough evidence to act. And that in that sense, we are in a causal inference framing. So we have some data over the summer on the policies, but we haven't really done much except putting this out. Hopefully other people find it useful too. Next, please. So you press the left button. We have 8 metrics to really show you the map, right? This is November 12th. You have cumulative cases, cumulative deaths, new cases, new deaths, and normalized by 100K. This is what I press is new cases per 100K. This is November 12th. And then you can also do a search. I put there Philadelphia County. You can also go to county. And on the left, we have the top 20 counties, whatever the metric you choose, one of the 8. And if you look at the top few, actually, they are the counties have very few population. So it's not really trustworthy just do the raw count. They have like a few 1,000. And then if they have 1 or 2 cases, it gets blow up. But you can search your own county. Next, please. This is the same map last time I gave it a talk. So you can see things got quite a bit worse, right? Just visually, you know. Even some of the very dark ones is a little lack of data or things very variable and got blow up. But still, there's clear evidence things got a lot worse since 6 weeks ago. So you can search next one. So this is Philadelphia County, right? Since I'm giving a talk in Temple. You just look at the blue curve. So the blue curve, we also do prediction of cases. And that's usually there's a lag about 3 or 4 weeks. So that's still pretty calm. But the blue curve, you can see that in like October just got picked up. There's definitely a slope going up. And on the left, you can see our confidence interval, prediction interval, still pretty decent for death. And case is not as ideal, but we don't miss too much. We didn't tune the method for case. We only studied for death, but we just use the same method for cases. And so the death is still pretty decent, around 80%, but definitely the case number is picking up in Philadelphia and in the rest of the country. Next, please. And this is new cases in Philadelphia County. The blue curve just picking up. Death is still low because there's a delay. So hopefully we treat better. That's what I'm hoping for. Then we won't see as a huge death with the number we have. Next, please. So how Response for Life, right? We very much was doing this modeling work to help Response for Life to distribute PPEs. We went for a pretty heuristic approach. So we end up, they build a Salesforce logistics system. We end up developing this severity index. We predict at the county level deaths, and we use the total number of employees of the hospital in the county to impute death count to different hospitals. And then we have the both cumulative deaths, as you said, the area severity, and then we also have the new count prediction. And then we cut into 3 categories. Both are high. We have high, medium, and low. So this is the indices the person who distribute will use, and we upload our predictions systematically to the Salesforce system, and they use it. We didn't really put into optimization. Even I recruited people to work with us, it was not called for. So we end up with this heuristic, like very categorical indices to use. Next, please. Actually, one of the shipment we did was to Temple University Hospital. 2 people I want to thank we work closely with, the founder of Respond for Life, Rick Brennan, and Don Lamworth was really the lead for the logistics. We work with Aero Bridget, like a group of pilots with planes, ship things for us because Rick is a pilot. And this is shipping on May 8th to Temple Hospital. And I think they helped us to distribute to nearby hospitals. Actually, one problem we had was we couldn't connect with hospitals at will. We call them, they don't know who we are, they wouldn't want to receive the shipment. So we can only use the places where we have contacts will receive the shipment. Next, please. So this is the Salesforce Response for Life system, and our severity index is uploaded daily, still now, but right now I think Response Life is not very active. And we work with maker spaces, Maker Nexus, and different local maker organizations to do. And also this get us PPEs. It's a residential medical doctors system because they have connections with hospitals to receive the shipments. Next, please. So as Edo mentioned, the paper appeared 2 weeks ago at Harvard Data Science Review. And when we submitted the paper, it was kind of, the reason actually we submitted the paper was because the website was up and running. We feel we need to make our work reproducible, and you have to document it, not just the code, but also how we did it. So that's why we wrote the paper. And for the revision, we had very, very good reviewers. So the paper became double the length. A lot of data quality results were added in the revision, not in the beginning. We just try to record what we did to support the website. Next, please. To summarize, the CLAP and the MAPI prediction interval are really generally applicable. We develop a linear exponential and some other predictors, but you can use your own predictors. Some are based on agent model, and this CLAP methodology we're able to combine and help to take the advantage of the best predictor, I would say soft way instead of hard choice way. And the MAPI methodology uses the past prediction interval, like prediction errors is also agnostic to the predictors, but you need to check a bit exchangeability for at least the period you're looking at. Over the summer, we worked on county level prediction for hospitalization, and we had UC hospital data. We really want to go to the facility level. We built a website we didn't put public for hospital to maybe use upload the data and predict their own hospitalization. We've been waiting for data from public health department, California State. So far, we haven't had access to that data. So we're still kind of finishing the work and hopefully get some data, more data. So the same methodology works for hospitalization with different initial predictors. Moving average works much better. So we change predictors, but not this CLAP and MAPI methodology. Next, please. To summarize, so this data repository is up and running. It's always there, and a lot of people have been using it across different universities and even some research organizations, and some actually startups contact us about the data. And the CLAP and MAPI are simple, transparent, and we actually right now still upload the data, but I think response line is not as active as in March. And we also support webpage Atlas at the University of Chicago. Next, please. So we are providing our prediction to a CDC forecast hub. Now many people doing county level prediction, and we're still in the middle of finishing the hospitalization prediction with different basic predictors. I'm kind of still on the verge of doing some causal investigation, but unclear there. We have policy data and haven't really made a decision yet whether to go there. Next, please. So the codes and data up there, and the website is called covidseverity.com. So hopefully you find it useful. Thank you.
Thank you very much, Ben. This terrific work. I think the index, the paper, the repository on GitHub with data encoded in the website are going to be a tremendous resource. I also want to say this is really the quintessential data science project. It's complex, it's collaborative. Statistics and machine learning methods have been tailored to answer the right question, the important questions, and also it's mostly automated. And like you said, having more humans in the loop would be great. And so I encourage everyone here listening today to take a look at the website. Thank you again for your perspective, Ben. That's been great.